Okay, I think we're about ready to begin. And we're recording this presentation, so I'd like to welcome everyone to this Midwest Meets session. It is a wonderful opportunity to hear Dr. Michael Davidson. And before I introduce him, I'd like to go over a few housekeeping items for everyone. We have a 1 hour limited session. Our lecture will go about 40 minutes. And if you have questions, there's a chat function at the bottom of your screen. And please submit any questions at that point, and I'll read them at the end of the lecture. This is an opportunity to hear from an expert, and it is a wonderful opportunity for everyone to learn more about CETP inhibition and obicetrapib. And we should begin now, and I'll introduce Dr. Michael Davidson. Dr. Davidson is a professor of medicine and director of the Lipid Clinic at the University of Chicago. He also serves as chief executive officer of New Amsterdam Pharma. He's a leading expert in the field of lipidology. He has conducted over 1,000 clinical trials, published more than 350 journal articles, and written 3 books in lipidology. His research background encompasses both pharmaceutical and nutritional clinical trials, including extensive research on statins and novel lipid-lowering drugs, as well as omega-3 acids. And Dr. Davidson is a serial biotech entrepreneur as well. He is board certified in internal medicine, cardiology, and lipidology. He was president of our organization, the National Lipid Association, from 2010 to 2011. And he is a wonderful teacher and a colleague and a friend. So Dr. Davidson, take it away.
Thanks, Jim. It's a great pleasure to be speaking to all of you this evening. And thanks for the Midwest Lipid Association. One of my greatest honors was being the second president, one of the founders, and the second president, Neil Stone, being the first president of the Midwest Lipid Association. So we're going to talk about CETP inhibition and obicetrapib. And the agenda is, I'll first give you a background about this is a very interesting and exciting target of therapy. Talk about the class and the lessons learned, and then specifically focus on obicetrapib and the clinical data that we have. And then lastly, I'm just going to touch on another exciting area that we're investigating, and that is the effects of obicetrapib on maybe mitigating ApoE4 risk for Alzheimer's disease. So let's begin with the biology of CETP. Cholesterol ester transfer protein looks like a tunnel that binds to both HDL and then LDL, and it transfers cholesterol ester in exchange for triglycerides in equal mass gradient transfer. And to think about it, it kind of makes lipoproteins more homogeneous. It moves cholesterol from where it's high to where it's low, triglycerides to where it's high to where it's low. And so in that sense, that's its function to do that. Now we know that this balance of HDL and LDL is largely driven by CETP. For example, animals that lack CETP, like the rat or the dog, have very low LDL, very high HDL, and they're resistant to atherosclerosis unless you transgenically give a mouse, for example, CETP. You make them atherosclerotically sensitive. And rabbits and monkeys and humans who have a lot of CETP, the more CETP you have, the more likely you can get atherosclerotic progression, especially with cholesterol feeding. So it's a very important protein for the underlying lipid levels in human plasma. So this is kind of how it works. It looks like a pancake that attaches to HDL. It bores into the HDL surface, and that tunnel that is created is thereby utilized to make that equal mass transfer between HDL and LDL. And so it's been exciting to understand that, you know, by binding to that tunnel pocket, you can affect how much transfer, you can block that activity between the transfer of cholesterol from HDL to LDL through that binding to that pocket, and thereby inhibiting that transfer. So let me go back and talk a little bit about, yes. Hello? Okay. So is everybody hear me okay? Jim, do you hear me, just to make sure?
I can hear you just fine.
Okay. Okay. I thought I heard some feedback. So the story begins actually in 1994, and this is why I'm very passionate about this target. I was the first one to patent CETP inhibition, and the patent didn't lead to anything specifically, but it was the idea of removing CETP as a way to reduce atherosclerosis. And as time went on, this became, you know, more and more of a target for the pharmaceutical industry to develop novel agents to inhibit CETP. And then while that was in progress, the genetics became, you know, very supportive of inhibiting CETP, because in the early days of genetic research, they could identify populations that had loss of function CETP, and this affected both HDL and LDL and led to lower cardiovascular risk. And the more you had alleles that were associated with loss of function, the more potent the lowering of cardiovascular disease. So there was a dose response on CETP, loss of function, and reducing cardiovascular events. So it had genomic validation even back in 2012 with the Copenhagen Heart Study. And as work went on, there was more and more kind of confirmation of this genomic validation through comparing it to other, you know, well-known targets of LDL lowering, like PCSK9 and HMG-CoA reductase, NPC1L1, different ApoB mutations, ABC, G5 and G8 mutations, SORT1 mutations. So these were all linked to, if you look at the equivalent amount of LDL lowering, you saw, you know, very, very comparable effects on reducing cardiovascular events, driven by LDL though, rather than the changes in HDL. That was a very important kind of rethinking about, you know, where CETP inhibition could result in a cardiovascular benefit. Well, but it was all linked to the LDL lowering effects rather than the HDL raising effects that was thought to be, at the time, you know, one of the really exciting benefits of CETP inhibition. And then further work, again, linking up all the targets that lower ApoB, genetic studies, and the degree of ApoB reduction and how that correlated with cardiovascular events was a linear relationship for all the different targets. And then with CETP inhibition, I'll go into more detail later, there was clinical validation of a CETP inhibitor, Obicetrapib, based on LDL lowering for reducing cardiovascular events. So the genomic validation has been entirely consistent with the pharmaceutical trials that targeted these different LDL lowering therapies. And that's what has been very exciting about genomic validation, has been very consistent. And whatever the biomarker effects are on LDL, for example, results in a very comparable effect on outcomes when we actually end up doing the clinical trials. And so this to kind of confirm, this is the most recent of these analyses that showed that across the board, you know, 16% risk reduction in CV risk for a 10 milligram per deciliter drop in LDL with CETP loss of function. Again, it's all driven by the LDL lowering effects of CETP loss of function. So with that said, you know, this class of drugs has had a very unfortunate history. And let me go through that with you and try to put in perspective, you know, what happened with very for high-profile failures in drug development. First was torcetrapib, a CETP inhibitor that was, again, developed primarily. They're all developed primarily for HDL raising. Remember, at the time, it was all about every 1% drop in HDL associated with a 3% increase in risk, and then we had data from VA HIT and other trials that showed that every 1% increase in HDL through those trials were associated with a 3% decrease in cardiovascular risk through HDL raising. And so there was this very much a mad dash to get HDL raising therapies into the clinic. And CETP, of course, with its high marked effect on HDL raising was obviously a very exciting target to do that. So torcetrapib was first. It unfortunately had an off-target effect, and it was known very early. I published the first phase 2 trial with torcetrapib showing raised the overall mean blood pressure by 5 millimeters of mercury. And in hindsight, we thought that that was, of course, not good, but with the HDL raising of 75%, we thought the HDL raising would offset any harm of the blood pressure increase. It was just unfortunate that this led to higher mortality in the phase 3 trials. And what we found out afterwards wasn't that the blood pressure going up was the issue, was that the blood pressure increase was directly resulted from aldosterone secretion by the adrenal gland, as well as other steroids. And the aldosterone secretion, we know in the setting of a high-risk cardiovascular population, led to higher mortality as it led to higher amounts of sepsis and cancer, all things that associated with high aldosterone levels. So that was an off-target effect. Since then, there's been 3 others that have gone into very large outcome trials, and the drugs have been very safe. No blood pressure, significant blood pressure effects, very safe. I'll go through each of them individually, but this off-target effect of torcetrapib has now been recognized even structurally on the molecule, what led to the aldosterone secretion. Next came dalcetrapib, a very modestly effective CETP inhibitor. It had no effect on LDL. What it did do is it raised HDL by about 30 or 40%. And again, that was the thesis behind taking that into a large outcome study, which unfortunately was neutral, had no effect on MACE. Another trial that went forward with called Dalgene looked at a specific subset of those patients where they thought there was a benefit, and that also was neutral, but it was affected by the COVID epidemic quite significantly, and what we did see a trends in the right direction, at least early in that trial. So there was hints of benefit in the second trial in particular, but overall there was no statistical difference on MACE. Very safe drug, and the benefit on diabetes reduction was quite compelling. It was 25% reduction in progression of prediabetes to diabetes or conversion of diabetes to non-diabetes. And we believe that, of course, is the HDL raising effect of CETP inhibition. Then came the Obicetrapib trial, which was, again, based on HDL raising. And in this trial, they went to acute coronary syndrome or diabetic population, and the LDL benefit was being determined by direct assay. And it turns out that the direct assay, just in general, is not very good, especially when you have low LDLs to begin with. So they had thought they had a 30% approximately LDL lowering, but it was really more like 15% based on other data we have from anacetrapib, as well as other trials with Obicetrapib in patients that had the beta quant measurement for LDL. And that study was futile at 2 years, stopped at that point with no benefit. But it did have a total mortality reduction that was significant. 0.04 was the total mortality reduction. So it was, again, very safe. But unfortunately, because it was based on HDL raising and not appreciating that the LDL lowering was not really as good as we thought, that it was way too short a trial. It was only 2 years trial with a relatively low baseline LDL. Then came the Merck anacetrapib trial, which was a very similar to Obicetrapib on LDL lowering in that 17% range. Again, thought to be higher based on a direct assay. But it went to a very large outcome study called REVEAL. I'll go into more detail about that in a minute. In REVEAL, thank goodness for us and for the field, Merck decided, of course, to think about HDL raising initially, but as time went on, and of course, with Obicetrapib failing in their trial to show a benefit, they did power the study for an LDL lowering, but it was not designed as an LDL lowering trial per se, as I'll share with you, because they started off with a very low baseline LDL cholesterol. And so that was an important learning. Now, unfortunately, that drug had a very marked increase in fat deposition, and actually crystals of the drug would form in the fat tissue. It would not plateau, continue to have fat drug deposition in the fat depots with a very, very long half-life. And Merck, even though the real trial was positive and showed a benefit, they decided not to file the drug because of concerns that if there was any long-term safety issues, that would be a problem for a drug like that, especially with that severe amount of fat accumulation. So that was unfortunate that drug never was filed because of that, for that reason, but it did importantly prove that the LDL lowering mechanism of CETP inhibition does in fact result in a cardiovascular benefit. And what we've learned over the years is that there's really two factors that drive clinical benefit. And I myself, to be honest, was really not aware of this until the last few years. And that is that it's not the percent LDL lowering that matters, it's the absolute LDL lowering, the amount of milligrams per deciliter drop in LDL that results in a cardiovascular benefit. And if you see the CTTC line, it's absolute LDL reduction and event reduction. In fact, the most recent Visperion, the bempedoic acid trial, is right on the line at 13% with a 23 milligram per deciliter drop in LDL. So that's consistent with the absolute LDL lowering showing a benefit on the line. The other major issue is time. You have to go long enough. In the first 2 years, you lose a lot of your benefit. It takes time for these lines to separate. And it looks like between year 3 and 4 median follow-up, you achieve your greatest benefit. Go longer, then you start worrying about loss to follow-up and things like that. And so we think 3 to 4 years is kind of the sweet spot for trial duration. So here's an example, why this is important on the duration. So absolute LDL lowering, you look at Obicetrapib and then the IMPROVE-IT trial with ezetimibe added to simvastatin versus simvastatin alone. The LDL deltas are roughly the same. Now, the IMPROVE-IT trial is higher risk. It had all ACS, with the accelerated trial with Obicetrapib having ACS and diabetes, stable chronic disease with diabetes. But you see the anacetrapib trial, after year 2, you see at 30 months, the lines separate, and they continue to separate over time. And so, again, thank goodness REVEAL did go long enough to show the benefit with LDL lowering with CETP inhibition. And so you have to go long enough and have a great enough absolute LDL delta to see a benefit. So here's just to share with you, kind of how this plays out for what we're doing with Obicetrapib. So again, REVEAL had a 61 milligram per deciliter drop in baseline LDL, 17% LDL lowering, 11 milligram per deciliter drop in LDL. You'd expect a 6% benefit based on the CTCC line. It was 9%. So it actually was as good, if not better than expected. There was 30,000 patients in this trial. If you look at the higher tertile LDL above 70, there was a 21% LDL lowering, a 22 milligram per deciliter drop in LDL, and a 17 to 18% relative risk reduction. So in the upper tertile, still relatively low LDL, but a greater absolute LDL lowering of 17 milligrams per deciliter, you saw this 17, 18% relative risk reduction. What we're trying to do with our trial is we have a baseline LDL of roughly 105 milligrams per deciliter on high-intensity statins or maximally tolerated statins, a much greater, as I'll show you the phase 2 data, much greater LDL lowering effect, 43%, that correlates with roughly a 45 milligram per deciliter drop in LDL. And that should translate into a larger relative risk reduction. And we've made sure that the last patient enrolled, which is very soon, our last patient enrolled will be in the next few weeks. They have to go at least 2.5 years post the last patient enrolled before we end the trial, even though it's event-driven as well. But the last patient has to be on drug for at least 2.5 years. So the median follow-up will be in that 3 to 4 year time frame for sure. So this is, again, the lessons learned from the previous trials to highlight that why it's important to go as high as you can on the baseline ethically, have the most potent LDL-lowering drug, and then give the drug time to realize a cardiovascular benefit. So this is why we're excited about obicetrapib. It has a very effective LDL-lowering efficacy. It's extremely well tolerated through phase 2. We're also seeing very good adherence throughout phase 3. The drug is very well tolerated. And so far, we're very encouraged by the safety of this drug, blinded safety in thousands of patients now in phase 3. But the unmet need is great. And we've unfortunately, I think, in 2013, when the guidelines were going based on evidence to not have goals, and then we went to high intensity statins primarily, and the goal message was kind of made a less of a priority. Now with the ACC 2022 expert report going back to 55 LDL as a target for those very high risk patients, we're starting to see growth again in statins and in non-statin therapy to address this unmet medical need. So we think the market is improving. We hope that'll translate into better goal achievement for patients, especially when a drug like obicetrapib comes to market in the next few years. Now, why is obicetrapib better? Primarily, it's a very, very potent CETP. It was made not to affect HDL raising was obviously a thought, but it was developed purely as the most potent CETP inhibitor. And while other CETP inhibitors reduce CETP in that 40% range for dalcetrapib to maybe 80% for anacetrapib or evacetrapib, this inhibits CETP by 97.6% at only a 10 milligram dose. The other CETP inhibitors are 100 milligrams to 600 milligrams of drug. And so we think this very, very low dose, of course, provides this great efficacy on LDL lowering as well as a great margin for safety for a CETP inhibitor. And so we have done a lot of work, as did Merck, on the mechanism of action. And so we are also replicating a lot of that work. We'll have more to share with you in the months to come about the MOA, about why it lowers LDL. But it lowers LDL, as I mentioned, in two ways. One, it obviously inhibits the transfer of cholesterol from HDL into LDL. So HDL goes up, LDL goes down. But it actually, what it does by slowing down the catabolism of HDL, less cholesterol reaches the liver, and thereby LDL receptors are upregulated, and therefore there's more clearance of LDL, from the plasma. So LDL receptors are upregulated. That was proven with anacetrapib by a trial at University of Pennsylvania with Dan Rader. You also get marked increase, I'll show you later, in TICE, transintestinal cholesterol efflux, where CETP inhibition does in fact result in tremendous amount of cholesterol removal, not just from the liver, but through the intestines as well. So here's just showing you the potency of obicetrapib on CETP inhibition and thereby its effects on lowering LDL. When you look at the beta quantification method of determining LDL-C lowering, obicetrapib for LDL lowering, ApoB lowering, and Lp(a) lowering is much more efficacious than both anacetrapib or evacetrapib. So here's our data. Here we have these 6 phase 1b or 2a trials, 2b trials. Most recently in Japan, rose first on top of high intensity statins, rose 2 as well. but also looking at in combination with ezetimibe. And so the overall pooled data shows a 46.7% lowering of LDL and a overall that's LS mean, MIT's median reduction, LS mean of 42.6, so 43% LS mean LDL-C lowering. And so what does that mean? So we looked at getting to goal. We looked at obicetrapib alone. You get this marked improvement in goal achievement. And then we're also developing a fixed dose combination with ezetimibe, which we're very excited about, where we can get almost everybody to below 70 and then almost 90% below 55 with one simple add-on to statins. So we think simplicity is going to be very important here. An oral, no food effect can lower LDL on that 40% range as a monotherapy, close to 60% as a combination with ezetimibe. It will be a very easy to add on therapy for anyone who's on statins, whether they're on high intensity or less than high intensity, moderate intensity, or even no statin if they can't tolerate statins. This would be an easy add-on to get almost everyone to their desired LDL-C levels. So here's the individual trial data on Lp(a). This is another exciting benefit. We're not seeking an Lp(a) lowering indication, but yet we see that in patients that have high Lp(a), obicetrapib, as other CETP inhibitors did, but to a lesser degree, it lowers Lp(a) somewhere between 57% in the ROSE trial to 47% with the ROSE2 trial as monotherapy. And in the REVEAL trial, what was interesting with anacetrapib, in the subset of patients with high Lp(a), the drug did seem to work better. So we do believe that this lowering of Lp(a), could translate to even improved outcome benefit beyond the LDL lowering effects of obicetrapib. We'll have to wait and see what the PREVAIL trial does tell us. Now, we're very excited about this combination with ezetimibe for two reasons. One is that the potency of lowering LDL. It lowered LDL by 63.4%, median reduction, 59% LS mean reduction when the two drugs were added together. And this was synergistic on lowering. We've seen here's the non-HDL lowering, and ApoB lowering is also, quite potent with the combo pill. And what's most exciting about obicetrapib that is unique about LDL lowering drugs is this benefit on HDL particles, and especially small particles. As we're all aware, I believe that statins lower all particles, but primarily large particles. And so what's left over is the smaller particles. And so we believe that is a large part of the residual risk of patients on statin therapy is they still have relatively elevated small particles. And to share with you our particle data, which we're going to present at the American College of Cardiology, 54.6% total LDL-P reduction with the combo with 72.1% total LDL-P reduction, but small particles, 92.7% reduction with the monotherapy and 95.4% with the combination tablet. So where does that mean? So we wanted to share with you, kind of what happened. So in the placebo arm, which is representing the active as well, they're all on high intensity statins. The LDL particles are roughly 1,000, of which 700 were small particles. The particle size was small. And when they were put on obicetrapib alone or obicetrapib with ezetimibe, the particles dropped to 495 and 300 respectively. Small particles dropped to almost nothing, 73 and 47, and particle size got bigger. So you can see how obicetrapib can really be a great complement to statins. So what statins do, you'll raise Lp(a), raise the risk of diabetes, and have residual small particles left after treatment. Obicetrapib would lower Lp(a), lower the risk of diabetes, and really profoundly lower small particles. So we think it's, again, a great drug to add to statins to potentially maximize residual risk reductions. Again, we'll hopefully prove that out with our PREVAIL trial. So what we did present at the MNLA meeting last June was the synergy here on ezetimibe with obicetrapib. Now, and as we're all remember, for those old enough, with simvastatin, ezetimibe, the hope was that, one would block synthesis, ezetimibe would block absorption. Absorption inhibition leads to increased synthesis, and synthesis inhibition leads to great increased absorption. So the two together would be a great synergy. We never really could show that clinically. That didn't seem to pan out. But here, what we found is that when we add we have obicetrapib, it profoundly increases the amount of TICE, transient cholesterol excretion, cholesterol excretion. And so it markedly does that. And so it obviously does improves cholesterol removed by the liver as well, but much more so as well through the intestines. And so when you have, more TICE and therefore more intestinal cholesterol removal, you have ezetimibe there to soak it up or to prevent its reabsorption. We see this synergy where we see even greater than expected efficacy on LDL lowering. We expect to see roughly 20%. We saw over 30% additional LDL lowering with ezetimibe plus obicetrapib. So I mentioned already, the drug is very well tolerated. We don't see any difference in side effects between the pooled obicetrapib and the comparator placebo versus for any of the side effects. And in fact, we see lower withdrawals overall versus placebo with obicetrapib in our phase 2 trials. And again, very, very excellent adherence in the trials throughout phase 3 so far. And then, of course, the one you worry about the most is the blood pressure with the torcetrapib history. And we're seeing no effect of blood pressure with this drug, again, in phase 2, as well as our follow-up data in blinded fashion throughout phase 3. We're seeing no impact of torcetrapib on blood pressure. And here's our phase 3 trial. We have Brooklyn and Broadway fully enrolled. They'll read out, Brooklyn will be first. They'll read out in the third quarter of 2024. That's our FH patient population, that LDL on high intensity statins still above 70 with probable FH. And then the Broadway trial is those with atherosclerotic cardiovascular disease, and that'll read out in the end of 2024. Those are our two pivotal LDL trials. One's 2,500 patients. That's Broadway 2-to-1 randomization. The other is Brooklyn 2-to-1 randomization with FH. Of course, we have the outcome study. We started that as early as we possibly could and learned the lessons from other LDL lowering agents. We're not going to launch the drug until the outcome study is completed. So that would be at the end of 2026 when the outcome study completes PREVAIL. Again, we designed it for success with a high baseline and a longer duration of follow-up. Then we have the fixed dose combination program. We just started our first phase 3 patient called Tandem with the fixed dose combination compared to obicetrapib alone or ezetimibe alone versus placebo. And that'll also be a part of our regulatory filings at the same time as the monotherapy. So these are the pivotal phase 3 trial. Here's Brooklyn. That'll be the first one to read out with FH. And then the Brooklyn trial with mostly ASCVD, again, over 55. We're very happy with the baseline LDLs. With Brooklyn, it's 120 milligrams per deciliter. And for Broadway, it's almost close to 100 milligrams per deciliter, like in the high 90s for baseline LDL. So we're going to see hopefully a good benefit on LDL lowering with these trials, hopefully in that 40% plus range as a single pill. In PREVAIL, again, we designed this for success. We don't want the trial to fail the drug. And so we've, again, learned from all the lessons that you want to go not bigger, because bigger and faster is not the way to go. We learned that from Fourier, which 27,000 patients, stopped at 2.3 years. The landmark analysis was important because if you're on the drug for only a year, the relative risk reduction went from 15% to 20%. So even having just 1 year of minimum follow-up made a big difference. We're having 2.5 years of minimum follow-up. The primary endpoint is going to be the 4-point MACE. And then we're also going to look at other other attributes of the drug, such as conversion of prediabetes to diabetes. And of course, we'll look at other combinations with existing therapies, especially GLP-1s and SGLT2s, which we have quite a few in these trials. So again, it was designed for success with higher baselines. If you didn't have a LDL above 100, you got into the trial with LDLs above 70, and then we lowered to 55. If you have risk enhancers like high triglycerides, low HDL, high LPLA, which we know from the REVEAL trial with Obicetrapib, had a better relative risk reduction. We also removed patients with a history of heart failure, because in the Odyssey outcomes and the Fourier trial, if you had a history of heart failure, you actually had no benefit. In fact, the hazard ratios were adverse. And so again, we want to take out patients that will not benefit. So we want to identify patients more likely to benefit and go longer with higher baseline LDLs. And we also want to add risk enhancers for those who do benefit better, but also remove patients where the benefits are not to be determined by LDL lowering, which is heart failure patients. We know that from other trials. They also look at LPLA lowering and the diabetes benefit, as well as dementia effects. So regarding dementia, I just want to highlight this. So we have invested in this science behind this. We think it's the HDL raising mechanism that offsets the ApoE4. ApoE4 is one of the most prominent Alzheimer's genes. About 2/3 of patients with Alzheimer's have at least one A4 allele. If you have one A4, you're about 3 times higher risk. If you're homozygous for A4, you're about 12-fold risk. Being a lipid gene, we believe that lipid therapy might be a part of the solution, but we know that LDL lowering with statins don't help, at least not in the plasma for Alzheimer's disease. But we know that adding CETP to an animal model like a rat, mouse, does in fact enhance Alzheimer's disease progression. When you have a CETP inhibitor, you improve cognition over time. And so we have animal data supporting the concept. We also have genomics support. If you look at Lewy body dementia, Parkinson's dementia, if you have CETP loss of function linked to the HDL raising effects, we see less dementia, especially if you have ApoE4, stronger with ApoE4. And again, the CETP genes do appear to protect against ApoE4 dementia in a publication back in 2010. In our preliminary data, we showed that obicetrapib does in fact lower 24 and 27 hydroxy cholesterol, which are made in the brain. And we know that statins don't lower these CSF levels of oxysterols. So we're excited about this finding. We also saw stable plasma biomarkers. It was open label, so we can't compare it to placebo, but these are all ApoE4 patients, a small study, proof of concept. So we saw disease, we saw target engagement with cholesterol levels going down. We saw stable biomarkers of tau and amyloid where you'd expect them to go up or get worse. We saw them be stabilized. Cognition as well stabilized in this small proof of concept study. So we are going to be looking at this in our Broadway trial with biomarkers of tau and amyloid. And if we see a difference, especially in those that have ApoE4 phenotype, we will pursue maybe another trial for obicetrapib in Alzheimer's disease. So thank you. I just wanted to really thank the Midwest Lipid Association, Jim in particular, for inviting me to address you. I know there's no CME for this program because I'm an employee of New Amsterdam Pharma, so I no CME. So I appreciate everybody coming on to hopefully learn and see what we're doing and hopefully share that excitement we have for this drug, and hopefully will prove itself out with our ongoing clinical trials. So thank you very much and look forward to your questions. Thank you.
Thank you, Mike. It was a very interesting discussion, and to hear your expertise in clinical trials was illuminating. I've been telling my patients for ages now, what you need to do to keep your pipes open is have the lowest cholesterol for the longest time. And if there's a sound bite that works, I think you were kind of helping me with some confirmation of that. So I would I don't have any questions now, so please, if you have any questions, put them in the chat function. I was going to ask Mike if you're able to hear me okay.
Yes, I hear you fine, yes.
Okay. I was wondering if you would comment upon the article that was in JACC, I think it was in October, by Flavio, I think it's Bicchieri, out of, I believe it was Brussels, where he and his colleagues were able to demonstrate triple regression of plaque when they were able to obtain the LDL cholesterol in post-infarct patients down into the 30 range. In just 1 year, they showed with measurements of a non-infarcted, non-culprit plaque using near-field spectroscopy, OCT, and IVUS. They were able to show triple regression in 1/3 of the patients in just 1 year when they were able to get their LDL cholesterols down in the 30s, again, in this situation, using a PCSK9 inhibitor.
Right. We believe the same thing, we're going to present data from animal studies at the EAS meeting that will be, I think, exciting to share about the regression of plaque with obicetrapib. So we're going to present that data coming up in a few weeks, in May. But the point, I agree with you. The point is that the LDL lowering is the key. Getting the LDL levels down will be the key to regression. And I tell I had my clinic today, and I was saying, your LDL is 80. It's not in the regression range yet. We got to get it lower, and so we're adding a PCSK9, especially because you have high LPLA. So those are the kind of like the type of things we like to share with patients about how aggressive to be. And again, we hope that obicetrapib can be part of that armamentarium to do that.
We do have a few questions now, and they are all of interest, and especially with the LPA reduction mechanism of CETP inhibition. Can you comment upon that?
Yeah, we don't know for sure why it lowers LPLA. Dan Rader did a study with anacetrapib showing it was decreased synthesis. We're going to also do that. We're also going to do a study to look at whether it's increased synthesis or clearance. We know that in animal models, CETP inhibition does increase SRB1 upregulation, increases SRB1. SRB1 is a receptor for Lp(a). So we do believe that could also be a mechanism. But we need to study. We're going to plan on studying this more in human studies.
And related to that, Dr. Heisler noted that CETP inhibition works via LDL receptor upregulation. How is it lowering Lp(a)? And you've also commented upon.
Yes, yeah, so I don't. John Kessler and I have a disagreement about this. I think it's clearance. He thinks it's synthesis. So we're gonna do the study to try to find out, what the mechanism is.
Okay. And a question from Dr. Stein says, with the failure of the AEGIS-II trial, does that have any impact on your obicetrapib dementia work?
No, not on the dementia side of things. That wasn't. I don't know whether they looked at that endpoint, but AEGIS-II, again, it's complicated because HDL, you gotta the brain and the plasma have totally separate cholesterol metabolisms. As an example, if you do a liver transplant in someone's E4, you put E3 liver in to somebody who's an E4, they'll have E4 in the brain, they'll have E3 in the plasma. So you just can't you can't get to the brain. LDL does not cross the blood-brain barrier. We know that, and so but we think HDL may interface in the choroidal plexus in particular. It may not cross that much either, but you need to get HDL chronically elevated into the choroidal plexus where it can interface with the brain, and thereby maybe efflux cholesterol out more effectively, especially when ApoE4 people cannot get their cholesterol out as much, and it becomes oxidized and then inflammatory, and then the amyloid and tau follow afterwards. That's our theory. So,
and obicetrapib does not cross the blood-brain barrier, I'm assuming.
just a tiny bit, just
Okay.
a tiny bit, yes.
A question here. I'm not quite understanding this. Perhaps you can help with it. Though it says what cancers are associated with high aldosterone level, and how does aldosterone cause sepsis?
Yeah, it was not. I misspoke a little bit. It was not the aldosterone. It also increased steroid synthesis dramatically, not just aldosterone. All steroids were increased, aldosterone being one of them. So steroidogenesis in general, as we know, does increase risk of sepsis and cancer. So that was the other factor there that was increased with torcetrapib.
Dr. Almosa, thanks you for that. A question again from Dr. Stein, asking about Dr. Castelline has said that this agent is a potential game changer because it's actually inexpensive to produce and may be offered at a lower price than PCSK9 related agents. He asks, is that still part of the plan? And I guess that's a business question.
It's a business way. Yeah, it's a very important question. We haven't, of course, decided on pricing yet, but that's the last thing you do before you launch a drug is determine pricing. But there's so many factors involved. But just to kind of get on my soapbox a little bit, the PBMs require these rebates, and so if you price a drug too low, you can't give them enough rebate to give you access. And so we want to our mission is to give broad access, and therefore, we decide not to launch the drug until we have outcome data in hand, and so there'll be no obstacle to getting broad access right from the beginning for the drug. That's our plan.
It would seem as though the combination of obicetrapib and a PCSK9 inhibitor might also be advantageous. What do you think about that?
Yeah, genomic data, there was a genomic study showing when you had both PCSK9 and CETP loss of function, the LDL lowerings were additive to each other. So we do have, 15% of patients in Brooklyn who are on PCSK9 inhibitors. So we'll be able to see what the additivity is there for those patients on with FH and already on a PCSK9 inhibitor. I believe they will be added. Hope maybe even more so. We'll have to see.
In the past, obtaining an ApoE genotype was prohibitively expensive, and now it seems to be very affordable and often covered by insurance. At least for many of our patients, we're able to get an E4. Can you talk a little bit about your experience? Should that be a test to be performed before prescribing obicetrapib in the future, or
well, for Alzheimer's, we think so. That's how we think it'll be. Again, we're a little premature, not knowing our data yet, but we think it's specifically an ApoE4 benefit. We don't know whether it would be working in ApoE3, but that's our focus is ApoE4 because it's the linkage between the genomics and CTP was ApoE4 related in the studies. And so that's going to be our focus in our phase 3 trials as well.
I recently gave a talk to ophthalmologists about lipidology, and there's all sorts of controversy about statins causing cataracts, and it's been pretty much dismissed. And Dr. Almosa is asking any premature cataracts with obicetrapib.
No, we don't see anything in all the animal studies, like with statins causing the cataracts in the animal models. We obviously didn't see that with our drug. So we're tracking all reports of any eye-related effects. We don't see anything. Again, we won't know till we have the bigger sample sizes to say about that.
It's interesting. In the next few years, then we're going to probably see medications designed to lower Lp(a), and here we have obicetrapib that may also be part of that. There's going to be a lot of competition for trying to pick the right agent.
Well, we're not going to get an indication for Lp(a). That's not our objective. So clearly, for the people that have really high Lp(a)s, it's going to be the the RNAi approaches or ASO approaches. So, but for a lot of people who are not like high enough to be eligible for those drugs, obicetrapib could be an option. At least from as an attribute. I mean, I think among lipidologists they'll know the data. It won't be on our label. It won't be on our label. This benefit. I don't think we won't have that. Unfortunately, we won't have that information. But we can. It's all part of the profile of the drug that we think is exciting. The Lp(a) lowering, the diabetes benefit, the small particles. Again, that fits well to how you can add to a statin to maximize reduction of residual risk.
Well, it's just a very exciting time in lipidology. I often tell my patients we have many of the things that will help prevent your future heart attack or intervention, and it looks like the excitement will only be building in the future. We have a hard stop now, but this is a recorded program, and you will be able to view this again if you're interested, or to have some of your colleagues come and view this from the NLA site. As president of the Midwest chapter of the National Lipid Association, I am just so proud that we were able to have Dr. Davidson give this really fantastic talk. And so I thank you also all for joining us.
Thank you, Jim. Thank you, everybody, for joining too. I appreciate it. And I see a lot of my friends on the line here, so I'm really look forward to seeing everybody soon at upcoming meetings, especially the NLA meeting in Las Vegas.
And with that, we'll conclude our program. Thanks for joining us, everyone.